Greetings, everyone, and thank you for joining with us on this beautiful afternoon at Quy Nhơn City. My name is Nguyễn Đăng Khoa. I will be your MC today. The HSIC Award was the Forum for Young Vietnamese Interventional Cardiologists for many years ago. Still, this year, we also welcome senior interventionists from Asia to come and share their deep knowledge. We also have 4 professional interventionists who will share their most challenging BCI cases in the third section. So stay with us till the end of the seminar and you will get precious knowledge from the leading specialists. So to begin, sadly to announce that Dr. Võ Thành Nhân and Dr. Nguyễn Thượng Nghĩa was due to the delay of the airline, so they cannot make it here in this afternoon. So I would like to introduce the other important panelists as our judges for the HSIC 2024 award. Please welcome to the stage Dr. Sozo Ishihara from Mimihara Hospital, Osaka, Japan. Welcome to the stage Dr. Lam Ho from Tuen Mun Hospital, Hong Kong. Please welcome to the stage Dr. Ngô Minh Hùng, Vice Head of Interventional Cardiology, Department Chợ Rẫy Hospital. Please welcome Dr. Panipa from Chiang Mai Faculty of Medicine from Thailand. Welcome all of you to the stage and become our panelists in this afternoon. Please welcome. Please take your seat. So we will begin, and with no more delay, let's start our session with the first presentation from Chợ Rẫy Hospital, entitled Optimal Timing and Choosing MCS Device for a Cardiogenic Shock ACS Patient Undergoing High-Risk PCI. Please welcome Dr. Lý Quang Trang to the stage. And I will have a brief notification for all presenters in this afternoon that your presentation should not be more than 12 minutes. And after that, you will have 6 minutes to answer all of the questions from our panelists. Please welcome Dr. Chang.
So good afternoon, everyone. My name is Dr. Sang from Chợ Rẫy Hospital. It's very honor for me to stand here to present the case to all of you. So we have the 52-year-old male patient with chief complaint of chest pain, 16 hours before the admission. He had a severe chest pain accompanied by diaphoresis and dyspnea. All the symptoms were persistent and progressively intensified. So he went to the local hospital where the diagnosis of the cardiogenic shock due to myocardial infarction with a Whelan syndrome was made. So he received the treatment including vasopressor, antithrombotic, and statin before transfer to our centers. He exhibits any medical condition except smoking for 20 back years. Upon admission, his very paralysis, cold extremities, high heart rate, low blood pressure with no adrenaline, and a normal oxygen saturation while under the mask. And then the condition deteriorated. He became severe hypotension. We have to escalate the dose of nonorine, and a severe respiratory distress. We have to endotracheal intubate and mechanical ventilate for him. So everything went serious and not easy for him right now. On the ECG, you can see the little elevation of ST from V1 to V4, and especially in ABR. On the laboratory test result, revealed elevated cardiac troponin, and the blood gas, you can see the metabolic acidosis with a very high latte level. On the X-ray, you can see the diffuse growth glass opacity and butterfly pattern indicated pulmonary edemas. But on an echo, we have the lobar left ventricular hyperkinesis with the AF just 14% and a TAPC just 14 millimeters, and no mechanical complication were observed. So we diagnosed this patient with the cardiogenic shock steady, biventricular dysfunction, and anterior STEMI 16 hours and kidney 4. So the revascularization strategy for this case, absolutely BCI first. In case the BCI not successful or failure, we can do BCI on the basis we go to the CBZ, that's clearly. And only revascularize the correct lesion. But a big question raised about the necessity of MCF device. Even though the patient has no serious comorbidities, but with very low cardiac function accompanied by the problem of left band on the ECG, it raises concern about the risk of the BCI. This patient becomes very high risk. The risk of cardiac arrest, the risk of arrhythmias, or complication related to the procedures. So using an appropriate MCF prior to the BCI allow more time to safely perform optimal intervention for him. So in a cardiogenic shock, with MCF, we can raise the cardiac output, you can maintain organ perfusion, and raise the chance for myocardial recovery. So to do that, we have the various MCF devices with different effects on hemodynamics. Some dominantly support the right ventricle, some left ventricle, some support the both like the ECMO. In our center, we just have the ECMO, we just have the IBB, so which is optimal device we want to choose for this patient? According to the shock state, when the shock deteriorated like this patient, we have to escalate the dose of vasopressors, we have to escalate the dose of inner trough, and with target organ hyperfusion, that's when we need to significantly raise the cardiac output. That's when the IBB no longer effective because it just provide a modest increase the cardiac index. That's when we need some device that provide a high flow like the ECMO, like the tandem heart, like the impeller. According to clinical scenario, this patient has the biventricular dysfunction. It's very important to mention the ECMO is the only device can provide biventricular support by just using a single device. So ECMO is the choice. So we need to know about the benefit and the risk we're going to face when you're using this device on the patient. The benefit, it clearly raises the cardiac power to provide hemodynamic protection during and after BCI. But about the risk, it's very important to mention that ECMO can increase the left ventricle after loss and the end-diastolic pressure, which it can worsen in myocardial ischemia, so which is a drawback in the patient suffering from cardiogenic shock. So to mitigate this concern, we can combine the ECMO with the other devices, like the impeller, like the IBB to underload the left ventricle. So we talk about the evidence base. Evidence is about the ECOS shock, latest trial in 2023, about the role in ECMO with the patient cardiogenic shock and myocardial infarction. This trial revealed that regardless of ECMO, the survival outcome of the patient didn't change. But it is disappointing in the result. I'm not so sure about this. We have some issue need to be reconsidered. First, the problem at times, most of the patients receive the ECMO after the revascularization, while before revascularization is thought to be more beneficial. Two, the problem of left ventricle underloading caused by the ECMOs, overloading caused by ECMO in a drawback in the patient suffering from cardiogenic shock. But just 5.8% in the ECMO group received the active left ventricle underloading, while this rate on the control group around 30%. Three, the problem of combined with other device. Up to 86% of control group received the impeller CB. Everybody knows the impeller CB, the potential device, can improve survival outcome in the patient cardiogenic shock. Well, this rate on the ECMO group is 0. So all these problems raise the concern about can bias the result of this trial. Who's no? But what if can optimize this problem, make it change the story, make it change the survival outcome, like this study. With over 200 patients with cardiogenic shock due to AMI, the ECMO before revascularization show more beneficial compared with after revascularization. But ECMO before the BCI raised concern about the door to balloon time. The ECMO, when it started before the BCI, can delay the door to balloon time. But in this study, the ECMO before the BCI did not significantly increase the door to balloon time. So the benefit easily outweigh the risk. So back to our case. Following the consensus on the heart team, this patient underwent peripheral ECMO through the femoral venous arterial cannulation in the cath lab within 30 minutes before the BCI. And you can see the cannula already in an inferior vena cava, and after connect to the ECMO system, the interventional team will see the RCA angiogram. And you can see the 70 to 80% stenosis in RCA, in the middle segment of RCA, and 80% stenosis in BDA. But on the left side, even though it's matched our prediction from the beginning on ECG, it's very uncomfortable for us to see the total occlusion in the left main. So initially, we used the hydrophilic with subtip wire, vesicant wire to attempt to grow the lesion into the LD. But with multiple attempts, the wire just advanced to the circumflex and could enter to the LD. So we decided to advance this into the circumflex and use 2-by-0 balloon to perform the balloon angioplasty and lesion, hoping to restore the flow from the left main to the LD. It makes it easier to navigate in the Y. And after that, we escalate from the Western Y to the bilateral 50, but didn't work. So the difficulty in navigating the Y was unexpected. So it prolonged the procedural time. So imagine this situation without the support of V8 mode. It raises concern about another potential outcomes could have been worse. So we continue to escalate from the bilateral 50 to the Gaia second, and finally successfully go through the lesion and enter to the LD. And next we use the balloon 2-by-0 for the lesion revaluation at the left main to the proximal LD, and this is the angiogram after the lesion revaluation, as you can see. So the lesion at distal left main near the bifurcation with significantly stenosis in the proximal LD and around 40 to 50% in osteum of circumflex. So the angle between the circumflex and LD is quite sharp. So it raises concern about circumflex when standing from the left main to the proximal LD. So we decided to adopt the proximal standing from the left main to the proximal LD and the gel balloon technique in circumflex to protect this branch. So we used the 3-by-0 dash from the left main to the proximal LD and the 2-by-0 balloon at the circumflex, as you can see. So after that, we both lighted it with a 3-by-5 NC balloon, and this is the final result, acceptable result with TME3 and no complication were observed. So after intervention, the patient transferred to CCU for more ongoing recovery. So hemodynamic is made stable throughout the intervention and afterwards. After just 6 hours after the BCI, we successfully discontinued the vasopressors. On the 7th day, the ECMO were withdrawn. And on the 8th day, the patient was extubated and went off the ventilators. And this is the follow-up echo, show that EF improved from the 40 to 36%. And the patient was discharged after 2 weeks with a stable condition and a stable hemodynamic. So after 1 month later, the patient came out with good condition, and the EF significantly improved to 43%, and a good cardiac result, cardiac boost. So through this case, we have something to mention. The V8 mode before the BCI can be more beneficial compared with the after BCI, and the heart-team coordination is very important. And optimal patient selection and timing is the key to improve the outcome. Thank you for your attention.
So, question 6 minutes. Yes. Okay. Yeah, so congratulations for your case. So my question is, do you think that what is the cause that
Xin thông báo, báo cáo viên chỉ còn 2 phút trình bày. Xin cảm ơn.
You use the Versaturn and then Pilot 50 and then with the Gaia second. So the nature of the problem is because of what? It's a CTO or what is the cause? Since if it's just only the left main, like ACS, that should be the solved one. So do you expecting that there will be something beyond that? Do you consider to use intracoronary imaging to see the distal part of the vessel in this case?
Yeah, thank you for your comments and your question. So from the beginning, we thought the myocardial infarction and a cardiogenic shock. We think that's the lesion resembling a thrombus near the bifurcation of the left main, but is the difficulty navigating the Y across the lesion into the LD is what expected. We don't think about that. We don't just think it's but easy to do the Y. But it's the harder, it's difficulty to navigate in the Y into across the lesion. Maybe this that thrombus, the reconstruction, or some kind of the new thrombus on the pre-existing calcified lesion. So to save the time tomorrow, to save the contract volume, we decided to escalate the Y from the beginning. But other option, we can use a microcatheter to more easily to navigate to the Y, another option. Yeah, thank you.
Okay, so very important point. So about the mechanical cardiac support, and so you, so even now, so the before so before revascularization or after revascularization, so mechanism, which is the best timing, is still controversial and discussion. You talk about that, and so this case, so hypertension, but still, so blood pressure is so there, so that. In my hospital or in Japan, so most hospitals are using IABP first. And so just for preparing ECMO. And if the patient collapsed at that time, so of course we quickly insert the ECMO. So that it's our, so maybe the Japanese style, so mechanical support. And also if some hospital can use impeller. Of course, it's also one option, but impeller is, as you know, very expensive. I think even in Vietnam, it is somehow limitation to use impeller. So that IABP is maybe, if the blood pressure is still low, but okay, at that time, IABP is first time still in Japan. How do you think about the role of IABP?
Yes, thank you for your comments. Everybody knows the most. Yes, IBB remains the most common used MCF for the patient suffering from coronary shock. Yeah, everybody knows it's easy to use, the low the cost, and effective some selected case. So just IBB just provide only the modest increase in cardiac index. So it's appropriate for the patient at the early state of shock, like the shock state A or state B, at a high risk of hemodynamic compromise. So when the shock deteriorated like this case, when it's steady, we need to some kind of significant raise the cardiac output, and IBB no longer effective. It just provide only low to moderate cardiac output. That's when the IBB is necessary for this. So, somehow can we combine the IBB2 and the ECMOs in order to the under low level? Because sometimes we did that. Yeah.
And also I have one more question. So that, for example, ECMO and impeller or ECMO and IVP, if we use both mechanical support, at that time we need two femoral approach. So we usually use PCI from radial, even the shock patient or so, for example, very complex case. So how do you think the approach? So PCI from femoral or PCI from radial, which is better for this kind of shock patient?
Yeah,
it's a guiding approach.
Yeah, in coronary shock is very critical. There's some imbalance. I think is the most. Imbalance is a very appropriate device in this case, but it's not available. It's in the most dangerous in the developed country in like Vietnam. So it's very. When the ECMO combined with the imbalance, IBB can decrease the pulmonary or edema, so it can provide optimal support for hemodynamics for the patient. Yeah.
Maybe I just ask one short question. When will you consider to do the PCI on the RSA? When will you consider to do PCI on RSA? RSA.
Yes. After 1 month, patient came out with us for the revisit. So we, with a good condition and a stable hemodynamics, with the optimal therapy, so we decided to complete revascular for the patient with the RCA. And we also do the repeat IVUS to re-evaluate the stenting of the left ventricle proximal LD for optimized.
Thank you. That's a good point. Yeah.
Thank you.
So thank you for the outstanding presentation from Dr. Lý Quang Sang. So we will move to the next case. Please welcome Dr. Phan Anh Khoa from Huế Central Hospital with the presentation, the most expensive lesion in patients with multivessel disease and high ischemia risk. Please welcome.
Yeah. Hi everybody, ladies and gentlemen, it's an honor for me to stand here and introduce my presentation. The topic related to the multivessel disease and high ischemia risk. The This is my case. The case report about the 85-year-old male with unstable angina. The patient have the medical history of the hypertension, control with medication, and hyperlipidemia. The presentation, clinical presentation is just new onset of the CCS3 of angina, and BMI was 24. The blood pressure is still normal, controlled by medication of blood pressure. And he has no prior CAD history. He's active, exercise, and have the normal ejection fraction on echo. The blood check is have a normal high sensitive troponin T, blood count, and normal the function of the renal. And ARC HBR is just 1 point. The patient was receive aspirin, clopidogrel, Vastar, Vancomycin, amlodipine, rosuvastatin, and Imdor. And we have a CA from January 33, revealed the calcified 3 vessel disease of 80 stenosis and the middle RCA, 50% stenosis is left main, multiple 80 to 95% calcified from proximal mid LAD, 99 calcified proximal LCX, and normal left ventricle ejection fraction. We calculate the SINGSTA score about 38, and after heart team discussion, the CABG declined, and because the patient declined it. Then patient was underwent PCI with the right coronary artery revascularization at after 2 days, and after 1 week, we do the rest. And this is the RCA. It's not too long and not too conservative patient in this picture, and we use the Buddy Y with the NC 2.75 balloon to prepare the lesions. And then we use 2 stents with 3.5 millimeter of diameter. But the middle is a little kinking, and we have to use a guide plus to support the stent manipulation. And then we have a NC, post-NC, and the final result here. Normally, we can see that this is a nice picture, and then we just stop here, and we don't do IVUS with this patient. And after a few days, we check the ECG is normal, improve the symptom. We have a normal creatinine and high sensitivity troponin T, and we have a new plan for the PCI with left main and LED LCX after about approximately 6 days after. And then this is the second revascularization strategy. You see, look at the left coronary artery is very heavy calcification here, and then we use 2Y to aortic and RCA, and you at least many balloon times of the LAD because it's very calcified and it cannot open the vessels. And after we have to use a NC 3.0 balloon that a little bit open better than pre-polarization. And then we check the angle again and use a stent with 3.75 diameter and 85 millimeter of length. And the second one is 3.5 millimeter of diameter and 40 millimeter of length. And then we require do the POT kissing balloon and then you do the last one of the LCX. Here, reopen again, and kicks in and final POT. This is the final picture of the RCA. It's look a little bit, it's okay, acceptable result, and we choose stop right here because it's very long time to do the publication with the 3 standard LCA. And just how do you think about this picture? Is okay, or we can stop here, or anything else happen to the patient? How about us? We choose the option we stop here because there's too much time to do this strategy. But after 10 minutes, just 10 minutes, when we transfer the patient to the patient room, the patient got cardiac arrest. And we immediately transfer the patient, go back to the cath lab. And we don't know the reason why the patient got this complication. And then we do the both time chest compression and check the angiogram again. We see that the LCA have a slow TME, but don't have any total occlusion in the left coronary artery. But in the right coronary artery, you see the total occlusion in the right coronary artery. And we tried to reopen with the temporary pacemaker and do the PCI, but after 1 hour, 2 hours of resuscitation, we did not succeed, and the patient will fall. And this is one of the big nightmare of us. So what is the big lesson of in this patient? Is there a early in-stent thrombosis? Do the patient have the clopidogrel resistant? Or or when we do the LCA too much time and make the ejection fraction lower and make the RCA become worse and right immediately and have a total occlusion right on the bed. And so we deeply understand and try to figure out everything and have a big lessons through this case. And for us, is have a take-home message. This is my lessons. First, is patient with multiple vessel disease with a high ischemia risk. High ischemia risk in this patient is the patient got too much stent. We have a multiple vessel disease. We have too much stent. The total length of the stent over 16 millimeter. So we should. It's better to use ticagrelor. And then we have to do the state PCI. Is a preferable option, because if I do not do the LCA, the revascularization, it maybe patient still survive. It's just a total occlusion, but maybe some small channel of collateral channel go back to the RCA and patient just still survive. And we have to use IVERT to help eliminate the risk of a high ischemia risk patient. Thank you very much for your attention.
Just simple question, maybe I don't follow. So when the patient arrests, have you echo to see if you have any cardiac tamponade in this case?
Yes, we have an echo right here on the cath lab. And then we check, we don't have any cardiac tamponade or epicardial effusion after the PCI.
Okay,
yes.
And at that time, you don't see anything abnormal for the ECG in the inferior lead, like to the AVF?
Yes,
Xin thông báo,
I
báo
will
cáo viên chỉ
explain
còn 2
detail
phút trình
about
bày.
the
Xin
scenario
cảm ơn.
patient after cardiac arrest. Right after the patient got cardiac arrest, we transfer the patient and check to the patient, but we check the lung is still okay. But the patient have a asystole, so don't have any normal sign or ventricular AFib, VFib or yes.
Yeah.
So we try to use the pacemaker implantation temporarily.
Okay, because for me it's quite it's quite not, if it's acute stent thrombosis at the time, I mean right after you finish with the procedure with the left main, so that should be something that happened from the ECG, or it should be like with TVF arrest. But this is asystole, right? And the second one, because the clot is really long according to the angiogram. I'm not sure whether that's already happens since the very first day that you did the procedure. So I'm not sure whether at that time that's, because as you mentioned that you don't use the intravascular imaging, so it's difficult to say that you do not have a mechanical thing that is the cause, especially for the stent under expansion, since the lesion is done in heavy calcified lesion.
Yeah.
Thank you.
Yeah, thank you.
For this case, I think you're just unlucky. Yeah, because the patient during the procedure, you must already give heparin. Anticoagulant is enough. And then with DAPT, anticoagulant, and then the patient still have acute stent thrombosis. That's very unlucky. Yeah. Is it the case near the Lunar New Year?
Yes.
Yeah, that is the traditional wisdom. Usually for elderly, don't do the procedure in the big
Yes,
festival.
thank you very much.
Yeah.
Yes, it's one of the big experience. Yes.
Yeah, so do you think the possibility of the HIT, heparin-induced thrombocytopenia? Do you know the HIT? HIT. HIT.
HIT.
HIT, yes.
HIT.
Yes, it means so giving heparin, so it makes thrombus, so that heparin-induced thrombocytopenia.
Oh, yes.
It may be so possibility, but unfortunately, patient gone away. Yeah, so that it's difficult to check test or something. So that if you see the similar case, so not only the PCI related lesion or vessel, but also other side. This time you treat the RCA, but LCA, but also RCA used so the thrombus both sides, so that it's sometimes due to the heparin-induced thrombocytopenia. Yeah.
Yes. Thank you. Yes, because the first procedure and the second procedure, the distance is about 6 days. Yeah.
Yes. So second time giving heparin or third time heparin giving is a very high risk. Yes.
Oh, yes. Yeah.
So thank you for the interesting presentation from Dr. Khoa. So before we go next into our next presentation, I would like to introduce Professor Dr. Võ Thành Nhân, our chairman of this session today, the president of the Ho Chi Minh City Society of Interventional Cardiology. Please give Dr. Nhân a warm applause. I also introduce our co-chairman, Dr. Nguyễn Thượng Nghĩa, Vice President of Ho Chi Minh Society of Interventional Cardiology, Head of Interventional Cardiology Department, Chợ Rẫy Hospital. And I also introduce one of our most important panelists, Dr. Ngô Minh Hùng, Vice Head of Interventional Cardiology Department, Chợ Rẫy Hospital. And we will move on to our next interesting presentation. Please welcome Dr. Trần Văn Đông from Hanoi Heart Hospital with a presentation, CTO in the high tech of right coronary artery, how to overcome. Please welcome Dr. Đông.
Good morning, ladies and gentlemen. My name is Trần Văn Đông from Hanoi Heart Hospital, and thank you for giving me the second chance to being here to share with all of you my little experience regarding percutaneous coronary intervention. As we all know that our Mother Nature has unlimited creativity, and one of her creation sometimes made trouble for us. And in order to be successful in such a difficult case like that, we need to come back to some really basic principle, really basic law. So that is what I want to share with you today. My patient is a 61-year-old male patient, and he admitted to the hospital because of really typical angina and shortness of breath. His medical history is not so significant with prior LAD stent about 5 years ago. All of his echo and ECG and lab result is not so significant. But due to his typical symptoms, the patient was transferred to the cath lab for angiography. And here's the result. You can see that on the left side of the heart, there is only mild stenosis at the middle of the circumflex, and the stent at LAD is still patent. On different view, you can see some signs of collateral circulation from the right. And as we expected, there is quite a long CTO at the middle of the RCA. And if we only had the CTO itself, it is easy, it is straightforward. But when we consider a little bit further, you can see that there is some abnormal in the origin of the RCA. So, if you look in detail the ostium of the RCA, you can imagine that if I stand here at the ostium of the left main, then you need to go in front of me and up high, and then that is when you meet the ostium of the RCA. So, in such an anomalous origin of the RCA, what kind of guiding catheter should we use to support for the guide wire to successfully cross the lesion? Because my civil once said to me, if you want to have a successful PCI case, you need to have optimal access. And what is optimal access? Optimal access means peripheral access like femoral or radial, or central access like a good guiding catheter. And in such a difficult CTO case, you need to have a guiding catheter with both coaxial and optimal support. So this is not the first time I deal with a RCA anomalous. Sometimes it goes straight down, so just using some kind of guiding catheter like a multi-purpose is okay. Or sometimes the ostium of the RCA is just like, but not the same with that case. That when I use a AL1020, and sometimes I'm combining it with a extension guiding catheter, or sometimes I'm just using a GL40 is enough for all of the lesion. And on the word, when I'm searching for the experience of other authors with RCA anomalous and CTO in RCA, I found a little case. Because CTO with anomalous RCA like that is rare. And it's even rarer for an interventionist to be successfully done such a case. Well, American College of Cardiology write an instruction for interventionists to be choosing the right guiding catheter for each position of anomalous RCA origin. We know that, and with all of the experience from me and also from other authors in the world, I tried the first attempt to intervene this patient, but we failed. We fail with all the guiding that we use, such as a AL10, AL20, EBU 35, 445, or even EBU 5.0. We fail. I try to use such more complex technique like anchoring to the left main and then rotating the tip of the guiding catheter to the ostium of the RCA. But as you see that if you want to successful with that technique, the ostium of the left main and the ostium of the RCA must be on the same plan, like the picture above. But in our case, it's not like that. And even I try to push the guide wire to the small branch of the RCA itself to anchoring for the guiding catheter. I fail. And the reason I will tell you the later. But after we failed the first time, the patient was discharged. And then 3 months later, he came back to us. He said he really want for his RCA to be recanalized, and we was willing to accept the challenge. But this time, we think a little bit further and back to the most basic and principal thing in cardiology intervention. That is the connection between guiding catheter, lesion, and guide wire. It is inseparable. So that if the lesion is straightforward, sometimes you did not need to put your guiding catheter deep into the ostium of the vessel that you want to intervene. You just need to keep it touching each other, and then the guide wire will giving support for guiding stabilization. And if the lesion is challenging, you need the guiding catheter must be stable and support so that it can facilitate guide wire to cross the lesion. So, what is the necessary condition and what is the sufficient condition for intervention in this patient with, some kind of very distinctive feature? And the necessary condition here is a good support. At the first time, we tried to use every type of guiding catheter, and we found out that with the EBU 4.5, that only our hospital have, we have 2 backup points. But a good support is not enough because the tip of the guiding catheter is not back up. And every time you try to pushing the guide wire through the lesion or even push the guide wire to the side branch, there is a counterforce deflecting the guiding catheter. So that we fail. So how can we add another force to counter the counterforce here? That is what we're missing. So the sufficient condition is stabilization. Well, we have a EBU 4.5 here, and we add another element, that is a unplugged superstiff. A superstiff is straight, originally straight, and when you try to bend it over a small caliber of the ascending aorta, it will create an elastic force. It's trying to straighten enough, and when it's trying to straighten enough, it will create elastic force. And so the elastic force of the stiff wire will counter the elastic of the guiding catheter, and also it will kind of stick the guiding catheter to the aortic wall so that we have 3 or maybe 4 backup points, and the 4 right at the tip of the guiding catheter. So the guiding now was significantly stabilized and ready for intervention. And here is what we done in reality. With the stiff wire, you can see that the guiding is really strong. It stands still in the aortic, despite of the heart still beating. And with that stable, we successfully deploy a micro catheter, and then with a Gaia 2, we cross the lesion. But after we cross the lesion, the guide wire itself now is some kind of support for the guiding to keep it in place. And if we want to push the stent, push the balloon to complete the procedure, we need to remove the superstiff. Remove the superstiff meaning remove the support. So that we need another support here. So that easy, just using a small balloon and then push an extension guiding catheter like this, as you can see on the imaging. So with all of that, we were successful to deploy a stent, and this is the final result. So my take-home message for this case is there is no human-made devices, such as guiding catheter, that's suitable for all the diversity of the natural human anatomy. The guiding catheter were made for the majority, not for all. And in order to be successful in some distinctive and challenge case, you need to come back to the basics. You need to understanding and also utilizing the fundamental mechanism. And greatness is achieved not by complexity, but by mastering the simplicity. Thank you for your attention.
Okay, very nice case. And so using the stiff wire of 0.35 is very nice idea, yes. And so maybe guiding selection of anomaly of RCA origin is so maybe discuss so many literatures like so you already showed. And also, so you use the guide extension catheter. It's also very important so option, but also so for this case there is a very big so conus branch, so that balloon anchoring also very important. So the combination of balloon anchor and also guide extension is also very so good for support. So first wire is easily advanced into the conus branch, so that using balloon anchor and the advanced guide extension, so that we can choose the next option. It's also one option. And another option is using double lumen catheter, like Crusade or something. So it's also the good support for penetration for CTO.
Yes, actually the stepwise is the final choice for us because we fail with all other strategy. We try to using extension guiding catheter. We try to use anchoring balloon to the small branch of the RCA, but we fail to push the guide wire through the proximal of the RCA because the guiding is so unstable, and every time it's like oscillating in the back and forth in the ascending aorta with every heartbeat, so that we was able to approach the ostium of the RCA, but when we push the guide wire to the tip of the guiding deflected because the guiding is so unstable, you know, so that every strategy like anchoring to the left main, anchoring to the small balloon, anchoring to the small branch of the RCA, we try but we fail, and so that's why we came up with the idea using stepwise. Yeah.
I'm sorry, I asked you a question. In this patient, you use the femoral access or radial access?
In this patient, we use
the last
radial access.
Attempt, yes, and the femoral, yes.
Yeah, femoral.
This is the case with the lower origins of the RCA, and the origin originated abnormal. It go to the in the front and go down. So in this case, I think the best guidance you use is be the MP 1 with 3 or 1 or 2 or 3 up to you after you to try. In this case, you use the ABU.
ABU 4.5.
Yeah, 4. Yes. After that, you make the curve.
Yes.
A curve go to the left.
Yes.
And go to the right.
Yes. Because right as the ostium, the RCA go up and then make a U-turn and then it go down. It's not go down straight from the start.
I understand.
If it's down slope right from the start, we can use AMB.
Yeah.
And I have so many cases with that MB before, yes, but in this case it's not like that. It's go up and then down with a U-turn. Yeah.
So it is not coaxial.
Yes, not coaxial at all.
For you
Yeah.
When you try to do the CTO lesion like this in the RCA. Yes. But you do the CTO lesion intervention, CTO lesion successfully.
Yes.
It's an interesting case. Yeah.
Thank you.
If we still have time, I will say something about your case. Congratulations. This is the abnormality of the origin of the RCA. Actually, if the RCA is go to the left side, so it's better to use the left guiding catheter in order to get it in first. It's not coaxial at the first time, and you will put the wire in, and then you can use the balloon at the proximal RCA to coaxial the guiding again, or you use the extension guiding catheter.
Yeah.
Because it is not, I think they're not very tough CTO, is it? Very easy to cross, but not very easy to engage the guiding catheter.
Yes,
Is it correct?
the CTO itself is not difficult, not so
yes,
difficult.
so the main point here is just the guiding catheter engagement.
Yes.
So we have to use the very gentle. Otherwise, you have to if you don't pay attention on engage the guiding catheter, you can cause a dissection, and that's very terrible in this situation.
Actually, when you're using such a stiff wire, like in my case, you have a risk of dissecting the aortic valve. Yes, so every move must be gentle. And we try using extension or anchoring before, but with this case, there is...
No, I just mentioning about
yes.
You just get engaged first, just close to the atrium of the RCA, and use the wire go in first, and use the balloon in order to direct the guy in. Without the balloon, you can cause the dissection.
The guy wire unable to, yes, thank you.
Okay, we will move to the next case. Thank you, Dr. Dong, for sharing your insights and innovative approach. So our next speaker is Dr. Truong Đình Phi from Vietnam National Heart Institute with a presentation about AMI due to SCAD, reperfusion or medical therapy. Please welcome Dr. Phi.
Good afternoon, ladies and gentlemen. I'm Dr. Truong Đình Phi from Vietnam National Heart Institute. I'm so glad to be here and share to everyone my case, a QMI due to scatter. So my patient is a 51-year-old female, previously healthy and employed as a nurse, has experienced sudden onset of severe left side chest pain during a night shift at the provincial hospital. Afterwards, she was transferred to our hospital, and her initial ECG indicated shift-based anterior MI with progressively increasing protein level. Her echo showed EF quite normal with apical hypokinesis. You can see her ECG at midnight. We showed a minor elevation at V1, V2, V3, maybe V4. And in this context, we decided to do angiography at 3 a.m. We can see the RCA and circumflex are quite normal. But for LAD, we can see the acute total occlusion of distal LAD. And at that time, we made diagnosis with anterior STEMI with acute total occlusion of distal LAD. But at 3 a.m., we have a loss of question in the young female patient with no traditional atherosclerotic risk factor. What is the underlying cause or mechanism of this patient? In this context, it is PCI indicated, or should we do the intravascular imaging such as IVERT or OCT for this patient? But however, when we look closely at the characteristic of distal LAD lesion, we can see that the lesion distal LAD is gradually tapered and narrowed, relatively smooth, and then completely occluded. And in addition, on the side, I think it's extremely important to how to diagnose is damage of diagonal branch. You can see here. And now we can make diagnose a provisional diagnosis damage due to SCAD type 2B for LAD and type 2A for diagonal. In this context, I think next step, should we do PCI or do we do the intracoronary imaging to make sure the diagnosis? But I think that's be 3 a.m. and I think requiring through the LAD very difficult and maybe to extend the digestion of LAD. And in this context, the patient is quite stable and has experienced only mild chest pain. So that's we decide to defer the procedure and give the patient the optimal medical therapy with anticoagulant, enoxaparin, DAPT with luplavin, high dose statin, beta blocker, and AEC inhibitor, and PPI also. And close monitoring to the patient in the hospital is very important and necessary. Simultaneously, we must look for the potential underlying cause with vascular assessment returning negative and normal lipid profile. We plan to do coronary angiography also in 1 week if the patient remains stable. And luckily, the patient remains always stable, has experienced mild chest pain on occasion, and her peak troponin reached about only 1,500. And when we do ECG every day, we notice that the ECG has started to be changed from day 3 with well inside. For me, I think that's a good side on ECG, because when we see this sign, it's almost certain that the LD has been revascularized. And indeed, when we performed the coronary angiography after a week, the distal LD was actually very clearly revascularized. And now, at that time, I think the wiring of LD is easy, and so that we decided to perform an IVR to confirm the diagnosis. Indeed, we clearly see the intramural hematoma limited above by the occlusion of diagonal 2. Afterwards, we maintain the optimal medical treatment, no PCI, and the patient has a discharge with the EPT, high dose statin, ACE inhibitor, and beta blocker. The patient, we plan a coronary angiography in 3 months if the patient remains stable, and advise the patient to avoid heavy exertion and not on due to asthma because she's a nurse. And 3 months later, the patient come back with us with no more chest pain, but gastric pain a lot. And ECG seemed to have a completely returned to normal. And we did angiography schedule at 3 months. We find that the coronary artery is quite normal with completely healed the dissection of distal LAD. And we make sure we did again the IVR, which show a completely normal LD without any atherosclerosis. And after discharge, because it has no any atherosclerosis distal LAD, we decide to adjust the medication of the patient, initially therapy, including monotherapy, aspirin, beta blocker, ACE inhibitor, and PPI. But due to aspirin intolerance, gastric pain, the patient was switched to Palavik. But we have to stop Palavik also because it's intolerant also from the March 2024. And until now, the patient is stable, no chest pain, abdominal pain, the blood pressure and heart rate is okay. For this patient, we have some discussion. For diagnosis of SCAD require comprehensive evaluation focused on the characteristics of all the coronary artery branch. The IVR OST is good standard for diagnosing SCAD, but may not be considered in each specific case, like my case. Because I think for writing for this LAD is very difficult and maybe propagate the dissection. A SCAD with complete coronary artery occlusion does not require revascularization with the patient is stable, and SCAD is not in the high-risk location like left main or proximal LAD or may be life-threatening ventricular arrhythmias. And for almost K and my K also, the conservative treatment regimen remains controversial, but for my case, anticoagulant, antiplatelet, beta blocker, ACE inhibitor were beneficial. And for almost case, I think 70% SCAD, the etiology is not clear, and close monitoring and repeat coronary angiography and essential in the SCAD management. The timing should be individualized, with most SCAD cases resolving within 1-3 months. And if the SCAD has been recovered without evidence of atherosclerosis, we can consider stopping any antiplatelet drug and starting according to international recommendation, is not exact. But for this patient, the patient could intolerate to monotherapy. Even we have to stop even antiplatelet therapy. And post-SCAT physical activity guidelines should be discussed with rehabilitation, especially to prevent recurrence. And I would like to share some key learning points from this case. We should be always vigilant and switch by SCAT in young female patients with few or no cardiovascular risk factor. And we have to evaluate carefully all the coronary artery branches to suggest the diagnosis of SCAT. Like this case, we found a lesion damage of diagonal 2. And IVAD OCT remains gold standard for definitive diagnosis of SCAT. And conservative treatment remains preferred strategy for almost cases. And patients need to be monitored closely during the hospitalization. Control coronary angiography need to be performed after 1 week before discharge and after 3 months to evaluate the progression of SCAT. And the cause of SCAT is frequently indeterminate. And finally, the physical regimen after SCAT is a key issue to prevent recurrence. Thank you very much for your attention.
So congratulations, and I think it's really the best practice as you inhibit yourself not to do anything else. Because otherwise, it's mostly of us like, okay, slow fall, so let's do something. It's really like itchy hand. Anyway, so I think you show
Xin
us
thông báo,
the way
báo
to
cáo
do the
viên
best
chỉ còn 2
practice
phút
for
trình
this
bày.
patient.
Xin
So
cảm ơn.
just only a few questions regarding this case. Have you considered in this patient you should go for the workup for the fibromuscular dysplasia or not? So this is the first question, because mostly of the SCAT, sometimes we have to think about the FMD as well. And the second question is that, in your view, because for the consensus, you can use either IVUS and OCT, so which one you prefer, and what is your view about that, in using the intravascular imaging for the SCAT?
I think for the second question, because I think if the evidence is revascularized initially, I think it's important to do the intracoronary imaging to confirm the diagnosis. But this patient, the distal LVD is occluded completely. So I think that for wiring through the LED is very difficult, and at midnight, 3 a.m., there is very serious if we cannot make wire into true lumen, and maybe the wire can extend the digestion of LED. And I think and the patient, the most important is the patient is stable at that time when we can defer the procedure after.
Okay, maybe I ask 2 simple questions. How to decide the timing of restudy angiogram in this sort of case while you choose medical treatment? How to decide the timing?
I think for this patient, when we choose conservation strategy for this patient, we have to make the patients stay in the hospital and with very close monitoring, and I think it's depends on the state of the patient. Is patient stable in our center? And I saw almost international recommendation that we will control repeat coronary angiography after 5 or 7 days after MI.
And then is how to choose the modality of investigation. Will you choose CT angiogram or invasive angiogram after 3 months if the patient is asymptomatic?
I think when if we do only the multi-slice to see the lesion, the damage of LED is not enough, because maybe when I think the resolution of multi-slide is not enough, and when we do the coronarography directly the intra-coronary intra-LED, we can see more information for confirm, for make sure the extension or the progression of scatter.
And for more distinct, more advanced question, how to choose between IVUS and OCT in this sort of situation?
I think the OCT is a good choice. I think an excellent choice for the patient with diagnosis of scatter, but OCT is not available in our center. And the more important, I think if the patient, if scatter has intimal tear, maybe with the OCT, when we inject, when we do injection, maybe the injection can't extend the dissection. And for me, I think IVUS is enough and safe for the patient.
Congratulations for a very interesting case. But I have a question for the older member of the panelists. After the first coronary angiography, personally, would you intervene or not intervene? Okay.
For the first case, depends on ECG, patient's symptom and hemodynamic, and of course also angiogram. I mainly consider these 4 factors to decide intervene or not. If I intervene, usually it's just small balloon open, make sure there's a fold. If there's a fold and patient is okay, then we'll stop. And keep monitoring the patient in CCU. If there's no symptom, everything stable, then won't do restudy. Restudy usually should be performed at least 4 weeks later, if the patient is completely asymptomatic and stable. If you really want to do intervention, you need imaging to guide. It's very difficult to talk without the case to illustrate, because the major concept nowadays is not dissection. For the scab, in fact, most of the case I see is spontaneous hematoma formation. If you use OCT, you can see that the whole intima is completely intact. It's just spontaneous formation of hematoma. In this sort of case, sometimes you need cutting.
This patient is a young lady, so that it is easy to understand this may be a SCAD or erosion MRI. So that maybe if it's too much distal, of course LA distal or RCA distal, we don't do PCI. But so relatively proximal part, we should consider doing PCIs. But so in this kind of situation, we should consider to use IVUS. Even in Asian countries, in Vietnam, in other countries, it is difficult to use IVUS because of the cost problem. But for this kind of case, IVUS is very important. And not putting stent is also very important because young lady. So that it's my opinion.
I would ask the question for the chairperson also. In this situation, in the final key message to the audience in this room, you give us that you leave it alone with the 100% occlusion of a very not very significant, not very important vessels. So in that situation, is it okay for the myocardium, the correspondent myocardium? I think that the myocardium has gone away. After 1 month, you check it up and you see that it's still, the vessel is patent at that moment, but at the acute phase, the myocardium already gone. So in this situation, you did the IVUS, and then you leave it alone because the hematoma, intramural hematoma. But the mechanical of this, the mechanical reason in this situation, it already is enlarged the lumen, compressed the lumen, and then it's make the TME flow already zero. So if you think that you leave it alone, it's okay for the patient or not? Because in this situation, I myself, I will do the, if I think that it is a SCAD, or I think the like a middle car, something like that, we can do this, use the small balloon in order to make it has some flow to the distal end first. And then we do the IVUS in order to make sure that this is the intramural hematoma. Of course, intramural hematoma, we don't do anything for that because it's healing itself.
Yeah.
For a couple of weeks later. And I don't agree with you that you leave it alone with the timid zero flow in this situation because the myocardium already gone because we cannot save the myocardium without flow. Thank you.
Yeah, I think the most important is the patient is stable. He has experienced
Patient stable is not mean that the myocardium is still alive. That's my comment in this situation.
Yeah.
Because sometimes the myocardium, the corresponding myocardium, still alive because it's very lucky that they get the cholesterol from the opposite side. So, but I don't want to leave it this situation like if the patient lucky, you get the cholesterol from from this opposite side. Thank you.
Yeah, I have a question for UOC. Also, because the patient doesn't interest to monotherapy, the antiplatelet event, and in my patient now, because I have seen the international recommendation for at least the patient after scatter, we have to use monotherapy antiplatelet, but the patient does not interested. So, what is your experience for this patient? We can stop for a long time antiplatelet, or we.
As an expert in IVUS and OCT, I would like to ask Dr. Panipa, what do you do if after the first coronary angiography?
In this case?
Yes, in this case. Thank you.
Yeah, I think during we see the OCT or IVUS, maybe you already see that the patient would have the plaque or not. If you see everything is clear, I would just put antiplatelet just only this short duration, maybe 4 weeks, because you are going to bring the patient back anyway. So it's clear, so it just stop because the patient will not have any benefit for prolong of the antiplatelet because you give antiplatelet just only to inhibit the platelet to go to the plaque. But if there's no plaque, I see no point to continue it.
Yeah, thank you.
For this case, I agree that OCT is very difficult because very distal the tube to the imaging part is very long, so you can't push to very distal. You cannot see it clearly. You need to use IVUS. Yes. Unless IVUS, you can't see clearly.
Not only this case, but for scanned case, it is difficult to remove the red blood cells, so that IVUS is recommended for scanned.
Sometimes IVUS cannot see clearly, and I do. This is some change of my whole concept in this few years. It's really you do more OCT and IVUS on those scabs, you find that some are really not dissection, no dissection, completely no dissection. The name scab is misleading. Most of the case actually is spontaneous formation of hematoma.
So all of you agree that in the first time, we will put a guide wire through the lesion and then use the IVUS to see what is the mechanism of the occlusion. Mm-hmm. And if possible, we will use a small balloon to get the flow back. But what do you do if after ballooning, there is still an occlusion?
It depends on the imaging finding. If you see some dissection, then you are more comfortable just try to do more ballooning. Because you see dissection, sometimes the hematoma, the blood in the vessel can come out into the coronary. If it's a full intact hematoma, you balloon just make the hematoma move propagate. That is my experience.
So just ballooning, and if it's successful, it's a good chance for the patient. But the question is that if it's not successful.
Yeah. Another way which is not recommended by many experts, but I found it work is you wire and then go to very distal. You use double lumen catheter, inject a little bit contrast, then you will know the distal landing. And then in the distal landing, you put one small stent, because for distal, even you put one stent, even it's young patient, very distal AD, one stent is not an issue, it's just one stent. This stent, Gary Min said it cannot prevent the progression of hematoma, but at least it can prevent the progression of dissection. After one stent, I think at least it can increase some resistance so that the progression of hematoma is less easy. Then you can use bigger balloon to open and then to see if you can establish the flow. Yeah, because with the distal stent it's more easy for you. And another thinking is to use some of the thinking if it's dissection, very, very severe dissection. You use imaging, you localize the place that is with severe dissection and is the entrance of the blood of the hematoma. I've seen someone said you just stent this part and then balloon and then it will be more easy for you to re-establish the flow.
Thank you.
There's some non-evidence-based way that I usually do before.
I think for me, because if from IVUS, I can see that where is the entry site and there's really no flow. Maybe I'll just stent just only the entry site and then wait. Yeah, just only the short one. You don't need to stent all the way because it's going to be the end of the procedure. And as we see from the IVUS, actually when the blood go out, it's just the vessel size go to 5 to 6, but actually the vessel size is just only 3 or 3.5. So if the IVUS can show you what is the entry side of the spontaneous coronary dissection, and you have no flow, just send at the entry side and then wait, just only to be patient of that. But if the lesion is let's say, to the left main, maybe you have to guard the surgeon back up as well, because sometimes we just cannot fix it. Yeah. So this is has written in the consensus in the ESC. So I think that should be the thing that we should know about that.
There's a guideline, a consensus published that you can refer to that, published by a lady, Malaysian lady, work in Canada or US.
Yeah.
Thank you so much.
Yeah,
and now we have the last presenter for this session, Dr. Panupokta from Maharaj Nakhon Chiang Mai Hospital, Thailand. And the presentation is entitled PCI Puzzle in Cardiogenic Shock Unstoppable Tales.
Good afternoon, everyone. Good afternoon, Mr. Chairman and our panelists and every audience. I am Dr. Panupokta from Chiang Mai University. Today, I'll be presenting the challenging and complex PCI case. And I name it the PCI puzzle in cardiogenic shock and unstoppable tales. Let's dive into our case. She is a female, 68 years, and with underlying disease of hypertension and dyslipidemia. And she presents with a typical chest pain for 2 hours at the private hospital. And at the emergency department in the private hospital, she developed the cardiac arrest with VT 1 cycle and the PEA for 1 cycle, but she achieved the ROC after that. In the left-hand side is the first ECG before the cardiac arrest and showed generalized ST depressions and mild elevations is AVR, maybe lesions with enlargement, something like that. But the true ECG is a right-hand side after the cardiac arrest. The rhythm is a complete heart blocks, ST elevation in inferior and depressions in posterior wall. reciprocal in the lead 1 and AVL. The acute inferior posterior wall STEMI with complete heart block is most likely at that time. Upon arrival to our hospital, the patient was in critical conditions with synod bradycardia and complete heart block. The rate is 30 beats per minute and unmeasurable blood pressure. We confirmed the bedside echo and no heart movement. And we immediately start the Lucas 3 chest compressions and transfer the patient to the cath lab. The medication before going to the cath lab is DAPT, aspirin plus ticagrelor, and inotrope is NOI and dopamine. As we began the procedure, I point to most likely the culprit lesion. I point to the RCA. I also insert the right femoral and right artery and vein sheaths and insert the transvenous pacing tube. I try a lot to engage of the RCA with JR4, take time about 8 minutes, and I can find nothing. And I change to the JL4 to see the left hand side to the left coronary artery, but the flow is very, very sluggish because she has no heart movement due to cardiac arrest. And the rhythm during PCI procedure is a PEA at 8 minutes. And for sure, the choice in our hospital right now is the ECMO, and we activate the ECMO team. But the ECMO in our ECMO team, the CVT surgeon is still in the OR for emergency case too. During waiting for the ECMO team, I try to engage again with the AL1, and I try for 25 minutes to find the RCA or the abnormal origins of RCA or something like that can explain our cause of cardiac arrest in these patients, but I can find nothing too. And after the CVT comes and insert the ECMO, okay, it has come, the situation is better than previous. I try again with the JR4 to engage the RCA, and I find nothing again. And I change to the AL1 again to find the RCA in the right hand, in the right coronary cusp, and I find nothing. But in the left hand side, I see something a little bit sluggish. You see it in the distal, very distal of the left circumflex. Maybe I see the flow, but the catheter is non-selective. And I change to the JL4 again. For the left circumflex, you will see the proximal left circumflex 90% stenosis, and the LAD is CTO, the LAD. But you see the collateral to RCA. The possibility is two things. One thing is a patient had a CTO or RCA with the collateral branch from distal RCA. And I changed angulation to the alveolar cranial view. I saw the tapering branch from the distal left circumflex to the RCA. That the vessel caliber is tapering. At that time, I think that, maybe patient are absent the RCA. That my first get okay. Okay, and then I try PCI to the proximal circumflex first. I pre-dilate with a SC balloon to 2/20 and put the stent in SES stent 2/28 and post-dilatation. And this is the angiogram after we PCI at the proximal circumflex. Everyone happy with the result, right? Because patient have the cardiogenic shock. And right now, the patient have no malignant arrhythmia. After ECMO, the BP is 96/65. And she's a little bit awake at E3, V2, and M5. And the contrast volume are not record right now. But the ECG and the inferior is a little bit elevated. But we should stop the procedure, right? But in this case, I continue to do it. Then I wire to the distal, very distal of the acute marginal branch. It acts from the left circumflex, and I pull out with small balloons. And the right hand side is the angiography after pull bar. And I still pull back on the upper branch of the RCA2. And should be finished right now. We get happy, everyone happy with the result. But right now, at that time, I'm continue PCI to the CTO LAD. At that time, I think that just touch a little bit. If that Y is stuck or it can't continue, I will stop. But the Y is feel the XTA and Y very, very easily into the distal LAD. And after pullback of the LAD, you see some recoiled segments of the LAD at the proximal and the mid. And then, sure, I decide to put the stent in the LAD from the distal to the proximal to the ostial LAD. And facilitation. And this is a final Korean angiogram in these patients. Finally, I PCI I put the stent in the proximal circumflex, pull bar on the distal, very, very distal circumflex, and put the stent from the ostial LAD to the distal LAD. But unfortunately, we lost the side branch of the DG1. Okay, and that time, the patient have no malignant arrhythmia. BP may improve a little bit, 100 over 75, and she fully awake right now. The total contrast volume is 320. And patient admit to the CCU in our hospital, and you compare in day 0 of echocardiogram, you see the ejection fractions is around 10 or 15, but in day 5 of the patients, the heart functions improve a little bit, and the ECMO setting it a little bit of vein of it. But unfortunately, she passed away because she have very massive of left hemothorax. So the conclusions in these patients, first one is anomalous Korean origin should be always considered. Maybe incidence is less than 1% in the absence RCA in general populations. And the second one, in hospital, extracorporeal CPR or the eCPR is very useful for facilitated hemodynamics and PCI procedure and can be life-saving doctor and patient in critical situations. The important thing is the complete revascularization should be avoided in patients with a cardiogenic shock, the evidence from the culprit shock. But we have a small observation study in patients with a suspect ongoing ischemia. Maybe PCI in non-culprit branch may be facilitated weaning off the ECMO. But the final conclusion is very important for me is you know when to fall in. That means you should know when to quit and stop the procedure. Thank you for your attention.
May I ask where did you put the ECMO? Is it in the cath lab or outside the cath lab?
Inside the cath lab.
Inside the cath
okay.
lab. And for this case, will you consider add on one more IBP? Because sometimes ECMO compare with ECMO plus IBPs, sometimes plus IBP may work better.
Yeah. Because in general in our hospital we generally use IABP, but in this patient, the patient has a cardiac arrest since she appears to arrive to the hospital. I'm afraid that if I put IABP at that time, maybe it's not work or it's not sufficient to support of the hemodynamic at that time.
I mean add-on therapy.
Add-on therapy.
Add-on therapy. ECMO plus IBP. Will you add on IBP?
In this case, or in my opinion?
Yeah.
I think it's better, but at that time, I'm not sure about the route of the access sites because they access both of the groin. We do PCI via the right femoral artery, but we put ECMO on the left side. But I'm not sure that where should we insert the proper side of the IABP. And in the literature review, combine the ECMO with IABP is maybe optimized PCI is better and facilitate to easy PCI.
Okay, so maybe the first using ECMO is important choice as you said. So and after the PCI, so using ECMO and also after PCI from right femoral, so we can choose the Cs from PCI guide to the IABP. So using ECMO and IABP is also one option to reduce heart stress, and it's one option. So maybe Dr. Hall also say.
And then nowadays, hemodynamic is very popular. So in this sort of case, in post-op care, will you consider hemodynamic assessment to guide your therapy? For example, white heart cath, cardiac output, CPO, etc.
You mean CTO?
White heart cath for the wedge, for the cardiac output, cardiac index, cardiac power output, all this hemodynamic assessment, which is quite popular recently. Of course, not evidence-based. Just ask query, will you consider all this hemodynamic assessment for those complex trip after procedure?
To be honest, in our hospital, we're not a routine to do the cardiac, the invasive cardiac monitoring, but it's a good point because I think it's in every literature it's very important to monitor, like you said, but in our hospital, not routinely.
Not a problem because we also not routinely do it. Just nowadays, it's a trend. People like to do it only.
In this patient, at the emergency room, when the heart rate go down, you don't push the pacemaker pulmonary on us.
I put pacemaker on the cath lab because we the cath labs, we have a cath lab and behind the ER. In our hospital.
From the heart rate go down, go to the patient cardiac arrest. How long?
How long?
How long? Yes.
I think less than 10 minutes.
10 minutes.
Less than 10 minutes.
Very quick, yeah. You do the CPR.
Yes.
With the machine.
Yes, machine.
The cath lab is behind the ER.
I have a question for you. How did you realize that the left side is the culprit lesion? Because usually we do the iliocranial and then we suspect something from the left side. Otherwise, it took quite a long time to find the RCA, where the RCA, and that the moment that we waste time. We waste time a lot, so we have to quickly realize that the left side, the left dominant is the one, like the circumflex. So usually we go to the left cranial angle view, and then we suspect, and then we just quickly. Because in this situation, I think that the time is very important, because if we slow to open the circumflex, so maybe we cannot save the patient's life. Thank you.
In fact, your case is very interesting and very rare for every operator, because while the patient on Lucas and then you try to engage the guiding catheter and then do the PCI, which is not common. So in your experience, can you give some tips? Which view will be better to do the, I would say, which view will be better to do the LAD? Because while Lucas is on top, you can't use the usual view.
Actually, but because you mentioned the machines is a very limited angulations. At that time, I used the LAO view and a little bit of cranial view, maybe facilitated, but from the machine is still limited to angulate, because I have a very long distance between the projection to the patients. But LAO cranial may be better in that time.
Oh, thank you so much for your interesting case. And On behalf of all the panelists, I would like to thank all the presenters and everyone who participated in the first session of the HSIC Award. And I hope you found the session meaningful and engaging, and we will move on to the second session. Thank you.